And today I'm going to be talking about prescribing Cascades and giving some highlights on the 2023 AGS Beers criteria. We're going to focus primarily for the Beers criteria on cardiovascular pearls. And in future presentations this year, as we continue, we will add in some additional pearls from other systems. All right, I have no relevant financial interests or other relationships with manufacturers of any commercial products or providers of commercial services that are discussed in this activity to disclose. And today, our learning objectives are going to focus around key cardiovascular recommendations in the 2023 AGS Beers criteria, identifying common prescribing cascades, and then practice recognizing potentially inappropriate medication use and prescribing cascades in older adult patient case scenarios. So the first thing I want to start with is just talking about the AGS 2023 updated Beers criteria for potentially inappropriate use in older adults. So this criteria was appropriate medication use in older adults. The criteria was published, or the new update was published in May of 2023. And this publication, or this new report here that we have, this new update, looks at literature that was published between June 1st, 2017 and May 31st, 2022. So that was the time frame they looked at when updating these guidelines. And so again, the Beers criteria for potentially inappropriate medication use in older adults is primarily for adults is intended for adults 65 years and older in ambulatory, acute, and institutionalized settings of care, but is not meant to be used for hospice and end-of-life care settings. And again, the information that we talk about here, these are recommendations that are potentially inappropriate, but always you have to think about your patient in this scenario. And there may be situations where you would need to use a medication even though it appears on the Beers list. The criteria this go around, this 2023 update, did have some reorganization. And so if you look at this publication, you'll see that the tables are organized a little bit differently, and there was some wording changes and kind of the order and the way things were shown that helped to make it a little more user-friendly, or the hope was to help make it a little more user-friendly. And they also did remove, or were intentional to look at items that were used very infrequently in the United States and to take those out. So again, it doesn't mean that they're all of a sudden okay to use in this population. It just means that because they're so infrequently prescribed, that they were not included in this update specifically. So a lot of adjustments just to kind of keep it as relevant as possible. So with that, the citation is right here, and this is an open access article, so you all should be able to access the Beers criteria to look at those in the future, or even after this presentation if you would like. And I'm just going to make sure that I'm monitoring that we don't have any questions as well. And with that, we're going to hop right into some of the highlights from Table 2 in the AGS Beers criteria. So these would be selected cardiovascular and antithrombic recommendations. So the first one is one that we've talked about in this ECHO and other presentations, recommendation to avoid aspirin for primary prevention of cardiovascular disease. So the guidelines, or the Beers criteria, do talk about avoiding starting aspirin for this indication, and also to consider deprescribing for this indication. The quality of evidence is high and the strength of recommendation is strong. So again, this is really only primary prevention of cardiovascular disease. It may still be appropriate for patients to be on aspirin for secondary prevention of cardiovascular disease. But for primary prevention, the evidence seems to outweigh, evidence of harm seems to outweigh the evidence for benefit. For warfarin and for the direct oral anticoagulants that we talk about today, they did comment in the updated Beers criteria that they spent a lot of time debating and organizing and thinking about how to put together these recommendations. So what we're going to see is a series of recommendations, and there's nothing, and then there is not a table, but a box that then tries to synthesize the recommendations as well. And I'll point that out when we get to that. But we're going to start with warfarin. And so for warfarin, it's recommended to avoid warfarin for the treatment of non-valvular atrial fibrillation or venous thromboembolism. And so the rationale or the recommendation along with this indicates that we should avoid starting warfarin for these indications unless there are contraindications or significant barriers to using a direct oral anticoagulant. Now, there were concerns amongst the writers and the individuals who helped formulate the opinions for the recommendations for the Beers criteria about access to the direct oral anticoagulants and whether that was whether all patients had equal access to those items. And they also indicated that if a patient was on warfarin and well-controlled with well-controlled INRs and no direct, no signs of adverse events or adverse drug reactions, and well-controlled for them would be an INR in therapeutic range greater than 70% of the time, then there was no need to change someone necessarily from being on warfarin to a direct oral anticoagulant. But if possible, when starting someone, it would be preferred to use direct oral anticoagulants over warfarin for these indications. So again, kind of have to think about all of the factors that play into that. But the reason for preferring direct oral anticoagulants over warfarin is related to bleeding risk. In Table 2, they also talked about rivaroxaban and recommended avoiding rivaroxaban for long-term treatment of non-valvular atrial fibrillation or venous thromboembolism. And the reason for this is because there's an increased risk of major bleeding and GI bleeding when compared to other direct oral anticoagulants. We also saw one of the direct oral anticoagulants commented on in Table 4 this year, and these are medications to be used with caution in older adults. And so it was use caution for dabigatran for long-term treatment of non-valvular atrial fibrillation or venous thromboembolism. The GI bleeding risk was greater with dabigatran than with warfarin, and GI bleeding and major bleeding risk was greater with dabigatran than apixaban. And so all of this together, kind of thinking about all of those things, let's look at our first case scenario. So we have a 68-year-old female with non-valvular atrial fibrillation who is seeing you in clinic for an annual wellness exam. Upon reviewing her medications, you see she is taking dabigatran, 150 milligrams by mouth twice daily. Based upon the updated 2023 AGS Beers criteria, which recommendation would you make? A, continue dabigatran 150 milligrams by mouth twice daily. Discontinue dabigatran 150 milligrams by mouth twice daily. Begin warfarin 2.5 milligrams by mouth daily. Discontinue dabigatran 150 milligrams by mouth twice daily. Begin apixaban 5 milligrams by mouth twice daily. Or discontinue dabigatran 150 milligrams by mouth twice daily and begin rivaroxaban 20 milligrams by mouth once daily. So what do you think? And I see some people are putting their potential choice in the comments, and I will leave that open for just a minute so that other people can weigh in their opinion as well. Perhaps in the same way, since there's not an official poll set up for this. All right, so I see a few people have indicated letter C, discontinue dabigatran, 150 milligrams by mouth twice daily, apixaban 5 milligrams by mouth twice daily, and that would be the correct choice as well, weighing that evidence. So box 1 in the updated Beers criteria does outline the major summaries related to anticoagulant use. And there's also another table that I think we need to look at when we think about anticoagulant use and looking at what the Beers criteria says about that as well, and that's table 6. And so these are the 2023 AGS Beers criteria for medications that should be avoided or have their dosages reduced with varying levels of kidney function in older adults. So there are a number of different anticoagulants that appear on this list. Some of them are ones we've talked about already previously. Others are ones that we would either avoid using or we would dose decrease with specific renal function. And so dabigatran, edoxaban, enoxaparin, fondaparin-ox, rivaroxaban are all on that list. They have varying levels of cutoffs for when they should be either dose decreased or avoided in the use of kidney decline or renal function decline. And so that's something important to keep in mind when you're looking at patients who are using anticoagulants that are also older adults. It's also important to remember that many of the direct oral anticoagulants have different doses depending upon indication. So they might have one dose for atrial fibrillation and another dose for VTE. And so you would need to make sure that you are considering the indication the patient is on as well as their kidney function in order to arrive at the most appropriate recommendation for a patient. So again, lots more clarification in these guidelines about kind of strategies for how to select a direct oral anticoagulant for an older adult as well. All right, so with that brief beginning of a date for the Beers criteria, we are going to talk a little bit about prescribing cascades, and we'll tie back in what the Beers criteria says a little bit about some of the medications that we talk about in this section as well. So a prescribing cascade refers to the sequence of events in which an adverse drug event is misinterpreted as a new medical condition, leading to the addition of another potentially unavoidable medication. Sometimes prescribing cascades are necessary, but many times there is an opportunity, if a prescribing cascade is identified, to go back and think about whether that medication is necessary or if there could be some other recommendation that's made either in the dosing of that medication or other alternatives that could help to prevent some of the adverse events that are being seen. So as a prescribing provider, there are questions you could always ask yourself when a patient presents with a new symptom or a new problem that they're experiencing. And the first one is, could a previously prescribed medication be causing an adverse event that appears to be a new symptom? And if yes, is that offending medication needed? If it is needed, is there a strategy you could take to best manage the adverse effect or symptom without creating a prescribing cascade? So this is going to help us as we think about preventing additional adverse events, preventing polypharmacy, and also thinking about deprescribing, because we've talked previously about deprescribing and how we decide how to eliminate medications potentially from a patient's medication list. And if that medication has arrived on a list because of prescribing cascade, that's a prime medication for potentially going back to the medication that maybe started it and trying to reassess at that point. So I think it's always good to look at the literature. There are a lot of different potential prescribing cascades that can be identified, but I really appreciated this article by McCarthy et al. and it is called Think Cascades, a tool for identifying clinically important prescribing cascades affecting older people. And this was published in 2022, and they actually did a modified Delphi process. And for those of you who may not be familiar with a Delphi process is a process where a group of experts come to consensus on what is most important. And so a modified Delphi process is a process that's used by the AGS-Beers criteria when they come to consensus about what should be included in the criteria as well. So this study design used a modified Delphi process. They had a panel of experts that included 31 to 40 clinicians per round. And so they did 3 rounds of questions to kind of try to narrow it down to what was included in the tool itself. And not all clinicians participated in every round. So they started off with 40, and by the 3rd round, they had 31 clinicians who were responding. The clinicians were from 6 different countries. The countries included Canada, Ireland, Belgium, Italy, and the US. And most of the individuals participating had at least 5 years of practice experience, but 23 of the individuals who were experts in the Delphi process had 15 years or more practice. And they had practice across multiple settings. The practitioners that were included as experts included geriatricians, general practice physicians, pharmacists, and nurse or nurse practitioners. And they started off with 139 potential prescribing cascades. And after 3 rounds, they ended with a smaller number, which the study team then reviewed and decreased to 9. So we're going to talk about the 9 prescribing cascades that were identified in the Think Cascades tool to help us consider when we might be able to see a cascade occurring. So the first results that they talked about were the cardiovascular system results. And so you'll see I have a table listed for each system that they ended up having, one or more potential prescribing cascades that were determined by this panel of experts to be the most common or ones that could be identified as clinically important. So the first one was a patient being prescribed calcium channel blockers and then developing peripheral edema, and then a second medication being prescribed diuretic to treat the peripheral edema that was in fact an adverse effect of the calcium channel blocker. The second one was a diuretic, which then resulted in urinary incontinence as the observed side effect, and a patient would then receive an overactive bladder medication to treat the first adverse effect of the first, or to treat the adverse effect of the first medication. So looking at this, it's also good to think about what the AGS-Beers criteria says about these medications generally. So calcium channel blockers, we see non-dihydropyridine calcium channel blockers are mentioned in the 2023 AGS-Beers criteria to be avoided in patients with heart failure with reduced ejection fraction. And that is one of the only places I was able to find that in our Beers criteria. But the overactive bladder medications may have strong anticholinergic properties. So we see table 7 talks about medications with strong anticholinergic properties. And we know that medications that have anticholinergic activity, if we look at table 3, we see patients are at increased risk of having falls, fractures, dementia, cognitive impairment, delirium. And in men, in table 3, they talk about anticholinergic medications potentially decreasing urinary flow and causing retention of urine. So certainly the first medication prescribed can potentially, by causing a side effect, result in a medication being recommended that is potentially inappropriate based on the AGS-Beers criteria. So I thought that was interesting, and we're going to see that in many of these prescribing cascades, in fact. When we look at Cascades results for the central nervous system, we see the first medication prescribed being antipsychotics, benzodiazepines, and SSRIs, SNRIs. And certainly antipsychotics and benzodiazepines are on the Beers criteria as well, and they are associated with, again, cognitive impairment and the development of dementia, increased risk of falls. SSRIs and SNRIs are also associated with increased risk of falls potentially as well. And we see observed side effects then shown. And as a result of that, we see additional medications that have been used to treat as a result of the adverse effect of the first medication. And many of these are also on the Beers criteria. So when patients are prescribed antipsychotics, something to watch for would be extrapyramidal symptoms. And patients can be then patients can then receive or be prescribed an anti-Parkinsonian agent, which would be an prescribing cascade. Benzodiazepines, there's a couple of different observed side effects that could result in another medication being added unnecessarily. And then SSRIs or SNRIs can cause insomnia, which can lead to sleep agents being added as well. So again, table 2 talks about anti-Parkinsonian agents with strong anticholinergic activity, antipsychotics, benzodiazepines, non-benzodiazepine receptor agonists. Delirium, dementia, cognitive impairment can be caused by antipsychotics, benzodiazepines, and sleep agents, and history of falls and fractures. We can see that with antipsychotics, benzodiazepines, and sleep agents, as well as antidepressants. So all of these are definitely clinically relevant to be cognizant of. The next one that they identified for the Think Cascades results was musculoskeletal system. The first medication prescribed was an NSAID. Patients experienced hypertension as a result of the NSAID use, and an antihypertensive was then added. Now, certainly NSAIDs also appear on the Beers criteria update, and NSAIDs are not to be used in patients who have hypertension or heart failure, and they can result in an increased risk of bleeding, GI bleed, or peptic ulcer, especially in older adults and in older adults on medications known to increase the risk of bleeding already. The next group and our final group was the urogenital system. So we have urinary anticholinergics, alpha-1 receptor blockers. For urinary anticholinergics, the observed side effect was cognitive impairment, and they were then prescribed a cholinesterase inhibitor or memantine. And for the alpha-1 receptor blocker, it was orthostatic hypotension and dizziness. And then the medication prescribed to treat that adverse effect was a vestibular sedative, for example, beta-histine, antihistamines, or benzodiazepines. And when we look at this list of medications, again, we see anticholinergics on this list. We see alpha-1 receptor blockers being on the Beers criteria as well, and antihistamines as well, having benzodiazepines and antihistamines, which also have strong anticholinergic properties. So keeping that in mind, let's talk about our first prescribing cascade or clinical scenario 1. So a 72-year-old female presents to your clinic to establish care. She currently lives independently in the community in her home and is an active volunteer and substitute high school English teacher. As part of her visit today, her medications are reviewed for appropriateness. Today, she reports her knees are bothering her quite a bit, and she's been having difficulty sleeping, which is limiting her ability to be as active as she'd like. Her past medical history includes hypertension, dyslipidemia, and osteoarthritis in both knees. Her current medications are hydrochlorothiazide, 25 milligrams by mouth once daily, lisinopril, 20 milligrams by mouth once daily, atorvastatin, 40 milligrams by mouth daily, and Tylenol, 50 milligrams by mouth, 500 milligrams by mouth as needed for knee pain. And you can see her labs and vitals here, as well as her current medication list. And the prescriber recommends ibuprofen 40 milligrams by mouth 3 times daily for osteoarthritis of the knee. So scheduling that instead of it just being Tylenol as needed for knee pain, and temazepam 7.5 milligrams by mouth once daily for sleep. So do you agree with these recommendations? So I see big capital letters from Elizabeth, no, and I would agree, Elizabeth. What are some concerns that you have? See the same from Mabel. Thank you for commenting in the chat. So suicidal ideation. Okay, from Robin. Any other concerns that you have? All right, so we know that, I'm going to go back to our previous slide. So risk of falls, ibuprofen for GI bleed. We do know, based on this scenario, that she's having difficulty sleeping and her knees are bothering her quite a bit. I don't know that we necessarily see that the patient has indicated in particular that she is potentially going to harm herself, but we do know that she is not able to be as active as she would like to be. And it appears that the things that she is most concerned with at this point are her knees, which we know she does have osteoarthritis in both of her knees, and her sleeping. And so I see a number of different things that have arrived in the chat, or a number of different comments about ibuprofen and GI bleed, or ibuprofen contributing to hypertension, and temazepam contributing to falls. These are all good things for us to keep in mind. So what would you recommend instead of this? So this is kind of the start of a potential prescribing cascade, but what could we do to maybe prevent a prescribing cascade from happening in the first place? So let's talk first about the patient's osteoarthritis. So is ibuprofen 400 milligrams by mouth 3 times daily for osteoarthritis of the knee reasonable for treatment of osteoarthritis in general? How about the loratadine or melatonin? The patient is not on loratadine or melatonin at this point. So that, I think, is talking about potentially sleep, perhaps, and how we might help with sleep. But let's go back to the osteoarthritis for just a moment. How could we approach osteoarthritis in this patient without using ibuprofen 400 milligrams by mouth 3 times daily? So I see scheduled Tylenol. So certainly the patient is taking Tylenol right now, but only 500 milligrams as needed. And I was hoping that someone would add in physical therapy or exercise, because certainly there are also things that we could do that are non-pharmacologic that may be able to help this patient, rather than starting with ibuprofen 400 milligrams. So again, thinking about what some of those options for treating osteoarthritis would be that don't involve medications on the do not use list or on the Beers criteria. And we do know that this patient does have hypertension, and we do know that ibuprofen can lead to fluid retention, or use of ibuprofen can lead to fluid retention and potentially decrease renal function. And so the patient's blood pressure could increase as a result of using this. And how about sleep? So what would be some non-pharmacologic recommendations we could make in relation to sleep? It is possible, and I guess we didn't necessarily, I'm going to go back to this. as well, but she's been having difficulty sleeping, which is limiting her ability to be as active as she'd like. So I don't really know what's causing her difficulty in sleeping, if it is her knees that are bothering her at night. So it might be worth finding out exactly what is causing the difficulty in sleeping. And then I see a lot of really good comments in the chat box about sleep hygiene care, looking at activity and eating habits, caffeine use, exercise use in relation to bedtime, even device use. You know, it's not just younger adults that are using their electronic devices late in the evening. It's also, or close to bedtime, it's also older adults who are using devices closer to bedtime as well. And sleep hygiene and cognitive behavioral therapy. So those are all really good recommendations to think about. Okay, so let's take it to the next step. So we have collectively thought of some things that potentially would be more appropriate for an older adult population, or could be used in an older adult population that would not involve the use of ibuprofen or temazepam, so an NSAID or a benzodiazepine. But to no avail, the patient did receive the medications and did then come in for follow-up again. It's been 6 months since she last saw her provider, who's currently out of the office on personal leave. So now she's seeing a different provider. She currently lives independently in the community in her home and is an active volunteer and a substitute as a high school English teacher, although she's not sure she'll keep substituting. She states, "My memory isn't what it used to be." Today, she reports her knees have been feeling better and she's sleeping better. She had her blood pressure checked at the senior center screening event last week, and it was 152 over 90 millimeters mercury. She checked it at home yesterday, and it was 150 over 88. So we see in her past medical history then, she has a history of hypertension, dyslipidemia, osteoarthritis in both knees, and insomnia. So then if we look at her vital signs and her current medications, you can see what she's taking. And based on her elevated blood pressure today, the prescriber would like to recommend amlodipine 5 milligrams by mouth once daily for high blood pressure. So do you recognize any potential prescribing cascades in this scenario? Adding the antihypertensive. Yes, so this would be a prescribing cascade. And what is it being added in response to? NSAID-induced hypertension, yes. So we're definitely seeing that. She's treating her for the increase in blood pressure, not reducing the ibuprofen, not recognizing that the ibuprofen is indeed the cause of the elevated blood pressure. So what would have been a better choice at this point? Let's say that you are the new provider and you're seeing this patient. You would likely recommend some of those things that we talked about instead of ibuprofen, right? Trying some of that as well. So perhaps scheduling Tylenol instead, which may or may not be effective for the patient. And also trying some of those other non-pharmacologic recommendations or other appropriate osteoarthritis treatment plans that are not including medication on the Beers criteria, if possible. Temazepam does contribute to memory loss. Thank you, Elizabeth, for noticing that. And yes, that is another potential prescribing cascade. So it doesn't seem like the prescriber here focused in as much on the temazepam because the patient said she was sleeping better, and so it seemed like it was effective, but it is potentially contributing to memory issues. And so we're starting to see that that could be a problem for this patient as well. We do need to do a med review again and look at Beers. So again, if we were coming in at looking at this patient initially, we might catch some of these things more so than if we were just kind of following up on the problems that are presenting themselves or the new potential problems. All right, so this is our third scenario. Same patient, 73-year-old female, presents to your clinic for follow-up. She did get prescribed the amlodipine. It's been 6 months since she was last seen. So now it's been a year since she first was prescribed the ibuprofen. Today, her daughter is with her. She currently lives independently in the community in her home, but her children have become increasingly concerned. She seems to have gotten more forgetful in the past year, and they wonder if she might be developing early stages of Alzheimer's. Her daughter also reports that both of her mom's ankles have been slightly swollen as well. Her blood pressure checks at the senior center have all been good, according to the patient's daughter. So then we see the medications that the patient is on: hydrochlorothiazide, lisinopril, amlodipine, atorvastatin, Tylenol is needed, ibuprofen scheduled, temazepam 7.5 milligrams by mouth once daily. And the prescriber recommends initially to elevate feet and limit salt in diet, consider compression stockings and diuretic use in the future, and recommend a referral for evaluation of memory concerns. What potential prescribing cascades are we seeing here? So amlodipine can cause edema. And so I see Mabel had indicated edema, not sure from which med, but that would be from amlodipine. So that is a fairly common side effect, and that is a common prescribing cascade. And so we haven't really changed the diuretic, but it is possible that the patient's kidney function is declined because of the ibuprofen use as well. And so, again, just looking at all of that would be important. But the amlodipine for sure is contributing an adverse event. And so rather than elevating the feet and limiting salt in the diet, could consider whether the amlodipine was needed, and that would back us up to through a couple of prescribing cascades, because we only added the amlodipine because the ibuprofen was added and increased the blood pressure. And then the referral for evaluation of memory concerns. We already talked a little bit about the temazepam, but benzodiazepines can cause memory concerns. And so while it's not possible to stop the temazepam immediately, it does have to be tapered over quite a period of time. It would be good to be recognizing that and to be able to think about how to taper that patient off of the temazepam so that they can see if the memory concerns are from the medication or if there really are indeed memory concerns.